Up next, we have Dr. Desai from University of Rochester, who will be speaking about carotid bulb distension index.
Thank you for the opportunity to present our work. This project focuses on how high carotid bulb distension index correlates with increased postoperative hypotension and ICU utilization after TCAR for elective asymptomatic carotid artery stenosis. We have no disclosures. Postoperative hypertension in this asymptomatic patient population is linked to unplanned ICU utilization, longer length of in-house stay, as well as increased morbidity and mortality. Underlying mechanisms behind why patients develop postoperative hypertension have yet to be fully delineated. We hypothesize that increasing carotid bulb distension correlates to postoperative hypertension after TCAR in this asymptomatic patient population. We did a single institution retrospective study using chart review as well as VQI database to pull up intraoperative as well as preoperative variables. Out of 187 total TCARs, we derived 103 index patients who underwent TCAR for asymptomatic carotid artery stenosis. We then did univariate and multivariate analysis with the primary endpoint being postoperative hypertension, which was defined by a systolic pressure sustained for more than 5 minutes of 90 millimeters of mercury or below, or a 20% reduction from the patient's preoperative baseline. We also looked at ICU utilization as a secondary endpoint defined by transfer or admission to the ICU within 24 hours of the index TCAR procedure. In order to quantitatively gauge carotid bulb distension, we used an index looking at the diameter of the post-stent dilation balloon, represented here by A, compared to the narrowest ICA diameter after initial stent deployment, represented in B. So for example, a patient who had an initial stent deployment and had a 4 millimeter ICA diameter and some residual disease and was later subsequently post-dilated with a 5 millimeter balloon would have a carotid bulb distension index of 1.25. These measurements were derived angiographically between subsequent diagnostic angiogram runs during their TCAR procedure. Looking at key demographics between the 68 patients that required no post-dilation and 35 that did, we found no significant differences. We found no significant differences in intraoperative variables. Flow reversal time was, as expected, higher in patients that required post-stent dilation compared to those who did not. However, it was not found to be significantly different. Hemodynamic measurements were also not different for these two patient groups, and stent parameters before post-dilation were not found to be any different. Postoperatively, patients who experienced post-stent dilation had a greater than twofold increase in ICU admission, as well as the presence of postoperative hypotension. These were both found to be statistically significant in our analysis. In looking at just patients who received post-stent dilation, patients who had post-op hypertension had a significantly higher carotid bulb distension index, 1.17 compared to 0.6 in our analysis. We see here that post-stent dilation correlates with increased occurrence of postoperative hypertension as well as ICU utilization in patients undergoing TCAR for asymptomatic carotid artery stenosis, and that higher bulb distension indices correlated with increased occurrence of postoperative hypertension. Our current future directions of this work is to validate this carotid bulb distension index prospectively, as well as looking at some anatomic measurements, and this may inform selective post-stent dilation in patients who are at higher risk. So far, we've seen that looking at calcium scoring seems correlated with the higher risk factors for requiring post-stent dilation, and these patients may have the opportunity to receive a anesthesia modality change like a regional cervical plexus block in order to mitigate the risk factor of developing transient postoperative hypotension. Thanks. I'll take any questions.
I drank a lot of coffee. I got questions today. So I think this is really interesting because what you're showing here is that the patients that have a lot of calcium are the patients that you're typically post-dilating. So have you changed your practice in any way? Are you using any adjuncts for calcium in the pre-dilatation arena specifically? Are you using lithotripsy for those patients? Or do you think maybe those patients would better be served by carotid endarterectomy rather than potentially with TCAR?
It's an excellent question. Regarding the first component of lithotripsy, we have not employed that, although we are considering using it and seeing how it modulates the calcific burden and possible stent dilation after. It could be a selective adjunct to mitigate that effect. In this population, we only looked at the asymptomatic patients. We can expand it to the symptomatic patients who do have a difference in our calcium scoring analysis, but that yet has to be published and looked at. But both points are excellent, and we'll continue pursuing those.
Dr. Garg.
Hey, great presentation. I really enjoyed it. Karan Garg from NYU. I have two questions. What is your criteria for doing post-dilatation? And second, did you actually take multiple views to confirm that there is indeed this difference between discrepancy between out and expense?
Yeah, great question. Most of these patients required post-dilation due to a 30% or greater stenosis in the residual ICA component of the treated portion within the stent, and that was what sort of was the impetus for requiring post-stent dilation. There were a few patients that had poor stent opposition, and when two stents were placed, that did have some overlap, but those were very small, less than 6 patients total. And I'm sorry, could you repeat that second component of the question? Oh, yes. In patients that required post-stent dilation, usually at least 2 completion angiograms were taken. The ICA, the residual ICA diameter may have only been 1 measurement, but the post-ICA diameter was calculated using both measurements. They were usually within 20% of each other's when those parallaxes were taken.
Thank you.